This is a very simple investigation done some years ago in the US. The idea is that what was touched upon also yesterday, that traditional risk factors are inadequate to predict cardiovascular risk. And this is the example to prove that, because you can see here it's 222 patients with first acute myocardial infarction, no prior coronary artery disease, no diabetes, and what we generally describe as rather young people that were committed to the department for first myocardial infarction. If they have went to their doctor the day before they got their myocardial infarction, the doctor would have said to them that they shouldn't worry, because in 3/4 of these patients or subjects, their risk would be low. And that resembled just the data we also saw from the recovery study yesterday, that around 80% or 75% of all the events occur in what we call low-risk patients. And that is a big problem, of course. Why is that so? One reason, at least, is that the risk factors need a lot of time to develop cardiovascular disease. And during that time, many different things can happen. So, of course, if you measure some risk factor here and over time it's changing, then it's not a good predictor. That is the problem with all the data we have, that normally we only have one measurement and then a long follow-up, and then we look at events. Another problem that I think is even more important is that there is a huge difference in individual susceptibility to risk factors. You all know the story about the old man who smoked all his life and says there's no danger in smoking. Of course, we know that is not true, but some people can survive even smoking all their life. What we hope, and what we have talked about also yesterday, is that measuring these subclinical organ damage measurements in one and the other way would be a way to tell us if the individual person is susceptible to the risk factors. So if you have, for example, high blood pressure, but have not developed subclinical organ damage, maybe you are not so susceptible for the high blood pressure as the one with a little lower blood pressure, but with more subclinical organ damage. And in the Monica cohort in Copenhagen, we did some investigations regarding that. And Thomas Sejersted demonstrated some years ago that it was quite correct that measuring subclinical organ damage as urine albumin creatinine ratio, left ventricular mass index, and pulse wave velocity surely increased risk independently of score. So you have here what you call low to moderate score risk below 5%, and here over 5%. And you can see in both groups, having subclinical organ damage clearly increases your risk. So this seems very promising. The problem is when you then continue for what you have to do to look at sensitivity and specificity, you can see here using score alone actually is rather good. You have a reasonable sensitivity and a reasonable specificity. You can, by measuring subclinical organ damage, increase your specificity. The problem is that you at the same time decreases your sensitivity. On the other hand, you can use another model, and then you can increase your sensitivity, but then you decreases your specificity. So the problem is that just adding these markers of subclinical organ damage is not the solution in itself. Why is that a problem? One explanation could be demonstrated on this slide made by Sarah Wikström. You can see here in green, that is subjects without any subclinical organ damage or any of the three measured. And you can see here, if you have low risk according to score, only a very few subjects have actually subclinical organ damage. On the other hand, if you have very high score risk, then almost all have subclinical organ damage. That was also mentioned yesterday, that the problem is you can measure a lot of different target organ damage, and if you measure enough, then you will always find it. So you have to grab this problem, because we can measure more and more. We have to know which marker should we measure, or which combination of markers should we measure, and in which group should we measure, because it's clear that it is not very beneficial to measure it in very low risk subjects, because you will look for it in a lot of people and find none. And in the high risk, of course, it would also be stupid because they all have it, so you don't need to measure it actually. When you then go to endpoints, you also have a problem. You have here the combination of, again, score. Low and moderate risk are pulled together because in the low risk group, the event rate was very low, of course. You have here the number of subclinical organ damage, 0, 1, 2, and 3. It seems very nice. Having more subclinical organ damage, then your risk is increasing. And especially the green bars looks very nice because they are steeply increasing. The blue is also nice. For the red ones, where you have very high risk by risk factors, then your gain by subclinical organ damage is not so clear. That is not surprising. But when you combine these event rates with the prevalence, you can clearly see here that most of the subjects are in the green bars, actually 70%. About these 3 out of 4 subjects are in the low or moderate risk. So if you want to look for subclinical organ damage there, you have to realize that you also have to measure it in almost all your subjects. There's not an easy way. You cannot reduce the number, and therefore it's rather expensive. If you then look at the prevalence the other way, you can also see that in general, most of the subjects do not have subclinical vascular damage, and very few have actually all 3 of them. If you then go to each bar, you can see that if you want to decide whether you have a cutoff value between 0 and 1, or between 1 or 2, or 2 or 3, then you have not only to identify the shift in risk, you also have to identify at what level you separate the largest groups. Because it's not so interesting, for example, if you only look at the low risk, if you look here in the middle, for example, I think it's easier to look this way. If you focus on the yellow ones, that is the group with moderate risk. You can see that is half of the population, and you can see that you have down here rather many subjects, down here very few. So that is obvious that you have to work down here, because if you have the cutoff value here, which would be sensible due to the risk, you actually could only identify a very little group of subjects. So we have to see beyond the difference in event rate and focus down here where you have a lot of subjects. So you change risk in a larger population. And the other problem, if you go to the blue and red bars, where you have the most subjects is in the middle here, but you can clearly see that is also where you have almost no difference in risk. So you always have to focus both of numbers, the prevalence and the risk, and I think it's very important to be aware of that. Then there's of course also other measures of subclinical organ damage. Estimated GFR and UNL mean creatinine ratio also very important. And there was a very nice meta-analysis in 2010, including a huge amount of subjects. And what they found was that actually estimated GFR wasn't associated with risk at a level between 75 and 105. But if you decreased risk, there was a clear increase in risk. And what was interesting was that, of course, UNL mean creatinine ratio was also associated with risk, and it was associated in a linear way. And most importantly, these two actually was associated at the same time. So although one could imagine that measuring a renal parameter as estimated GFR would be an either-or option, they can actually add to each other. So that is also important to know that. Another risk factor a marker that we haven't touched much upon is ankle brachial index. The problem is actually, I guess, that it's rather old, and the technique hasn't been much in focus, because if you look at this meta-analysis, you can see very clearly that it's clearly associated with risk in all studies, and you have this very clear curve, both in men and women, that if you have an ankle brachial index around 1, then you are at the lowest risk, and when it is decreased, then the risk is increasing. But what is not shown very clearly here is that the number of subjects that have this very dramatical decrease in ankle brachial index are very small. So again, you have a defect or a marker that if it's affected, the risk is very high. The problem is that it's very few that have this. So for populations, screen is probably not as useful as many of the other markers. This was just to demonstrate also that it's additive to Framingham risk score. If you have 5 categories of Framingham risk score, you see in each risk score the same U-shaped association. And then Stefan taught us a lot of pulse wave velocity yesterday, so this is only one slide from one of the first publications demonstrating the independent risk predictive value of pulse wave velocity, showing that it is independent both of previous cardiovascular disease and age, and heart rate predicting outcome. So surely, as a risk predictor in the general population, it's very nice. And data on treating this parameter we look forward to, of course. Yes, and this is actually the same, but just for women instead. Then intermediate thickness was also touched upon by Stefan Laurent yesterday. And this is an Italian study demonstrating in patients with hypertension this is from the, yes, it's patient with hypertension, that having an increased intermediate thickness in the blue is associated with more risk than having in the other quartiles. But as you can see, going down to the single events, the numbers are very small. But what is interesting is that they also did on-treatment treatment measures of intermediate thickness here, and what they demonstrated actually was that on-treatment values was not very predictive. As you see, for all cardiovascular events, it was actually the baseline value. It was only here you had the treatment value as being significant for the cardiovascular events and major cardiovascular events. It was the baseline value that was the strongest. Of course, you have more events here, so that's a reason why there's more power up here. But it's striking, at least for me, that the baseline value is better than the on-treatment value. In the live study, we also looked at this and showed that urine albumin creatinine ratio and Sokolov-Lyon criteria added to each other, so measuring as a kind of kidney parameter together with a parameter for left ventricular hypertrophy had additive effect, so that if you had an urine albumin creatinine ratio below the median value and the Sokolov-Lyon value for left ventricular hypertrophy below the median value, you were at a very low risk. Having both, you were at very high risk. And in between, you had an intermediate risk. We also demonstrated that if the urine albumin creatinine ratio was decreased during treatment, as shown here, you have the baseline values here in red versus green, And then 1 year values, both times it is the median values that divide in high and low. You see that the group with the lowest risk was, of course, them who entered with a low value and stayed on a low value. But actually, if you were on a low value, but next year were on a high value, you were actually at the same risk as if you were starting on a high value. And having high value also after 1 year was the highest risk. And this was also significant when adjusting for all the other variables, also the reduction in blood pressure. And in the same way, it was demonstrated in a live study that a reduction in left ventricular mass by 1 standard deviation was associated with an improvement in both the composite endpoint, cardiovascular death, stroke, and all-cause death. It wasn't significant for myocardial infarction, and that was probably because in the live study, patients were randomized to either atenolol or losartan-based treatment. Losartan was better to reduce left ventricular mass, but of course, atenolol had a protective effect on myocardial infarction that is well known. So maybe that's the reason why it didn't become significant. What we then did afterwards, although the power is not very strong here, we tried to see can actually measuring subclinical organ damage with ECG and urine albumin creatinine ratio during treatment add to Framingham during treatment. So what you see here is that you have in this line the basic risk stratification or model for risk, and that includes the Framingham risk score, the urine albumin creatinine ratio, the Sokolov-Lyon ECG, and the history of cardiovascular disease. Then after 1 year, we included the Sokolov-Lyon, the Framingham risk score measured after 1 year. Not surprisingly, it was non-significant. That is seen many times because we treat blood pressure, we treat cholesterol, and therefore measuring the traditional risk factors are not any longer associated with risk. If baseline Framingham wasn't included, then it would be significant, but not as significant as the baseline value. And you can also see the -2 log likelihood is exactly the same. But then if we instead include subclinical organ damage measured at 1 year, then we actually decrease the -2 log likelihood, telling us that this model is a little bit better. It is only a little bit better. It's an incremental bit better. But in principle, it demonstrates, not surprisingly, that measuring subclinical organ damage during treatment can add some information. And of course, it is reasonable to understand that if we believe it is a marker of susceptibility to risk factors, it should also be a marker of susceptibility to the treatment we introduce. So if a patient do not regress during treatment, the patient is not as susceptible to the treatment as another patient, and therefore we should adjust our treatment. We have not tested that. That is only a hypothesis that if we then increase treatment, it will go, the prognosis of these patients would be better. But that is actually the idea in the study Stefan was telling about with pulse wave velocity, because the idea is by measuring pulse wave velocity during treatment, you identify patients that do not seem to react although the blood pressure is reduced, and then you intensify the treatment, and it will be very interesting to see whether these patients will have a better prognosis over time. Based on these data, you can rank in some way the different markers of subclinical organ damage. You have the predictive value, availability, reproducibility, and cost effectiveness. And if you take them together, you will end up that the best and most cheapest measures are the ECG, estimated glomerular filtration rate, and microalbuminuria. So the evidence is at the moment strongest for these. But then, of course, you also have the echo with the left ventricular mass, the carotid intermediate thickness and plaque, arterial stiffness, and ankle brachial index. So that is what is recommended at the moment, but of course that will change over time, surely. And if you want to get a more, let's say, standardized grip on whether you should use one of the other, you can go into what the European Society of Cardiology have done for some years, using classes, level of evidence and classes of recommendation. The problem is, as I will demonstrate very soon, is that for many things you will end up with a level B that is in the middle. You have data from 1 or 2 randomized trial or 1 randomized trial, so it's not so strong. And you end up as a class 2. You can either recommend A or you can disrecommend, and then actually you are not getting much wiser because you are in the middle all the time. But if you would like to do that, you will end up like risk stratification using SCORE model in asymptomatic patients with hypertension without cardiovascular disease or diabetes. That would be what I would recommend as a 1B. And you would then have subclinical organ damage, would be recommended, particularly in patients with moderate risk, and that would be a 2AB. And then looking for the ECG, the estimated glomerular filtration rate, and urine dipstick or urine albumin creatinine ratio or excretion, that will be a 1B again. And then the echo, the ultrasound of carotid arteries, the carotid femoral pulse wave velocity, and ankle brachial index at 2AB. And as I said, I haven't demonstrated any, let's say, very strong data. We are not getting much wiser, unfortunately. So my hypothesis is that maybe we are actually looking in the wrong way, because I fear that we will not, with a single measurement of marker subclinical organ damage, be better in risk prediction. But maybe we can understand why certain people are reacting differently to to the same treatment. So to get more clear, closer to stratified treatment. And just to make an example of this, I've done this very crude diagram where in the population survey we had, I have divided the group in patients with totally normal ambulatory blood pressure, intermediate ambulatory blood pressure, and elevated ambulatory blood pressure, and then with and without target organ damage. And what you clearly see here is that increasing blood pressure are almost not associated with any risk in the green bars, but a rather steep risk increase in the red bars, indicating that maybe, as I started out saying, these markers of subclinical organ damage might be markers of susceptibility. So maybe we are not doing the right thing when we are taking huge populations. Maybe we should go for smaller groups, because we know that subclinical cardiovascular target organ damage carry additive prognostic information. The problem is that we don't know if they have an additive effect, and the other thing is that is most important, we don't know whether the individual risk assessment and treatment monitoring are varying. So the idea is that I think we should focus more on making what you can call stratified measurement of target organ damage. So not in everyone, but find the right group for the right measurement and then use it in that group. And then I will finish out with just mentioning that we are trying in European Society of Hypertension to gain new knowledge within this area through a initiative in the Center of Excellence called Gyrotopic. It's importance of genes and interactions on risk factors for target organ damage and prognosis in a prospective intervention cohort. Unfortunately, we haven't got money for EU, so it's very difficult to include, but we hope some of you will participate. Thank you for your attention.
Thank you, Michael, for this excellent talk.